Welcome everyone. We'll just wait a minute or two just while more people are coming into the webinar. We'll just get started in a moment. Well, we might get started. Thank you everyone for making the time this evening to join this educational webinar on genetic testing for melanoma. My name is Shannon Anderson and I'm the CEO of Melanoma Patients Australia, and I'll be facilitating this webinar this evening in partnership with Melanoma Institute Australia. Melanoma Patients Australia is a not-for-profit organisation that provides support services, including information, telehealth nursing and peer-led support groups nationally to melanoma patients, families and carers. And our purpose is to support, connect and advocate for Australians affected by melanoma and to work towards its prevention. Melanoma Institute Australia is dedicated to preventing and curing melanoma through innovative world-class research, treatment and education programs. And Melanoma Institute Australia's mission is to reach 0 deaths from melanoma this decade. I'll introduce tonight's speakers shortly, but before I get started, a moment. Just importantly, I'd like to acknowledge the traditional owners of all the different lands on which we come together this evening. I'm on the lands of the Wurundjeri people of the Kulin Nation in Melbourne, and I'd like to pay my respects to elders, past and present. I also extend that respect to any Aboriginal and Torres Strait Islander people joining us this evening. So just in terms of a brief bit of housekeeping, this webinar is being recorded and it will be uploaded to the MIA and the MPA websites in the coming days. In terms of any questions, if you can please type any questions you have using the Q&A button, and we'll endeavour to address these during the Q&A session and at the end of the evening. Please ensure that your questions are of a general nature, as we cannot give personal medical advice in this forum. We do value your feedback, so please complete the brief online survey after the webinar, which should appear at the conclusion of the webinar. So also, I'd just like to mention this is the first webinar in a 3-part series. So we do have some other webinars coming up over the next couple of weeks. So next Tuesday, one on understanding melanoma drug therapy in the new era of neoadjuvant, and also another on Tuesday, the 24th of June, a deep dive into sunscreen. And you're still able to register for those webinars, and we'd love to see you there. So now I'd just like to introduce our wonderful speakers for this evening. So I'd like to introduce firstly Associate Professor Linda Martin, who's a dermatologist with Melanoma Institute Australia. Linda is the Director of Dermatology Services at MIA and a staff specialist, paediatric dermatologist at Sydney Children's Hospital. She's also Associate Professor of Dermatology at the University of New South Wales. And I'd also just like to introduce Tanya Dwarte, who's a genetic counsellor from New South Wales Health. Tanya is a senior genetic counsellor at the Hereditary Cancer Centre at the Prince of Wales Hospital and the Cancer Genetics Service at St Vincent's Hospital, Sydney. She's board certified by the HDSA and supports individuals and families with inherited cancer risk, helping them navigate genetic testing and ongoing care. So Associate Professor Linda Martin will commence with our first presentation, and then she'll hand over to Tanya shortly after that.
Hello, good evening, everybody. I'll just get the slides ready. So thank you for the invitation. It's a pleasure to be with you this evening. I'm joining you from the Eora lands of the Gadigal people in Sydney. And I would like to make a special note that the way cancer genetic services are set up does vary from state to state. And so if you do have any specific questions, probably Tanya may be able to answer them in the chat afterwards. So this evening I'm going to talk about genetic testing for melanoma, really focusing on who would be eligible. So this is a photograph of me, thanks to Danielle, from quite some years ago. But it's common that when we see patients in clinic, they have a lot of questions. Melanoma is a scary diagnosis, and there are a lot of questions that people have. What does this melanoma mean? Will this melanoma spread? Will I find another one? Will I find it in time? And this evening in particular, we're going to talk about why me. Why is there a genetic reason why you got this why a patient is to get a melanoma versus a constellation of environmental factors. And also importantly, patients often have a lot of questions about their kids. So I'd like to start off by discussing the difference between tumoral and germline mutations. You may have heard of BRAF mutations. The most common one is V1600E, and that's a genetic alteration in an individual melanoma cell or melanoma tumor, which is something that oncologists or pathologists might order because that may determine a patient's susceptibility or eligibility for specific types of targeted treatment for advanced melanoma. But what we're talking about this evening is germline mutations or germline genetic alterations. So these are genetic variants which are occurring not just in a tumor, but in every single cell of your body, and also in the ovaries or the testicles. Apologies to the gentleman, I only have the ovaries marked on this diagram. And this is something that you may inherit from a parent, or it may be a new variant in a specific individual, and it's something that may be handed on to the next generation. Now, in Australia, the lifetime risk of melanoma is 1 in 12 for men and 1 in 18 for women. So it's actually not uncommon that we will have a patient who has one relative or even two relatives with melanoma just due to that very high baseline population prevalence. But there is an official definition of familial melanoma according to the FAQ criteria, and that's a cluster of 3 family members in first or second generations. However, even if you have a cluster of melanoma in your family, if you look at this diagram, by far the most common causes are just genetic skin color, so fair-skinned individuals combined with an environmental risk, which for us is living in Australia with very high ambient UV levels and a very outdoors lifestyle. So we're receiving a lot of cumulative UV exposure. So the number of patients who will be eligible, even with a strong family history of melanoma, for genetic testing is actually quite small. And in this, we have about 1% of patients will have very rare genetic diseases. For example, xeroderma pigmentosum, which increases risk of melanoma by 10,000 times, P10 tumor hematoma syndrome, etc. And generally, in these very rare genetic diseases, melanoma is not the diagnosing feature. Often these individuals will be diagnosed in childhood because they'll have multiple other system manifestations, which will alert their parents and the treating doctors that there's a diagnosis to be made. Then again, the majority of people with inherited melanoma, so a variant causing melanoma, is still going to be something which is not really detectable with modern genetic testing. It may well be that there's a genetic variant that we haven't discovered yet, because looking for genetic variants is still a little bit, Tanya can correct me if I'm wrong, like looking for needles in a haystack. And what we're really able to test for at the moment in Australia is an inherited mutation in CDKN2A, which is a specific gene, and a variant can be passed on in an autosomal dominant pattern from generation to generation, causing an increased risk of melanoma. and pancreatic cancer. So here I have a picture from Shutterstock. I stole this from the internet. We have a family of very fair-skinned individuals. Sorry, I'm about to have the first child crashing the lecture. Shh, okay, okay. That's Cecilia. I think she's crashed every lecture I've given. I'm sorry in this forum. Here we have a family with very fair skin and really unsafe, sun-safe behavior. You can see there's no shade and very little, no hats and very little clothing. So say we have one member of this family with a melanoma. Does that mean his daughter or grandchild has an increased risk? Well, I'd say in Australia, their increased risk is going to come from their genetic skin color and their behavior of UV exposure. What about if we have two parents, both parents having melanoma? Again, that doesn't necessarily mean that the children or grandchildren will have an increased genetic risk of melanoma, but more that focusing on sun safety in skin cancer prevention is very important. But then if we have a father and daughter and possibly another sibling, then we have a cluster of 3 individuals, and that is the type of family which will alert our concern that this may be a genetically inherited variant with a measurable risk. So these are the currently funded Australian guidelines for referral for genetic testing. They're the FAQ guidelines, and you can find them online and you can evaluate it yourself. It includes 4 parameters, which includes the age of diagnosis of melanoma, the number of primary melanomas, of the patient filling out the form, the number of relatives up to 2 degrees, and whether or not there's a history of pancreatic cancer. We then look at this 4-factor score, the bottom one, including all 4 risk factors. And currently in Australia, if that score is greater than 20%, we meet the criteria to refer to a cancer genetic department for CDKN2A testing. However, just because this number is positive doesn't mean that we're going to have a positive result. As we said, even if there's a high pretest probability, there's still the majority of cases of familial melanoma, we do not find a genetic variant. So I'd like to run through some patient scenarios with you, looking first at CDKN2A, which is the most well-described and most common single gene variant. The first patient I have had an acral melanoma, so a melanoma on the sole of her feet when she was in her 30s. So it's an early age of diagnosis and an unusual site, not a photo-exposed site. Her parent had died from pancreatic cancer, but before she died, had testing for CDKN2A and was known to be positive. So we have a 50% probability that this patient here is positive. They definitely meet the criteria for testing, given they have a known family member. However, this patient chose that she did not want testing. She didn't want to know. She was happy to continue her melanoma surveillance with the presumption that she was positive, but didn't want that personal information to change her life outlook. Then again, I have another patient. This patient also had a parent who died from pancreatic cancer. In this case, she didn't have the CDKN2A testing because it was some time ago. Our patient had her first melanoma at an early age and has now had 7 subsequent primary melanomas. So this again gives us a very high index of suspicion that there may be a genetic carriage. This patient was referred for testing and is still negative. So that doesn't mean that they don't have an inherited cause. It just means that they don't have the CDKN2A mutation, the most well-described mutation for familial melanoma. And then I have another family here. In this family, the first patient had metastatic melanoma in adolescence. Now, that's incredibly rare. The risk of melanoma in childhood is 1 in 10 million. And then she also had a child who developed a melanoma in adolescence. So in this family, they meet criteria for testing. Their testing was positive, which reinforces the need for us to continue our screening. But most importantly, in this family, allows de-escalation of screening for non-affected siblings. So in this case, there's another sister who tested negative, who then doesn't need the same degree of follow-up. And finally, I have a patient, a case example, a patient with 3 primary melanomas, but also had bilateral premenopausal breast cancer and ovarian cancer. So although she doesn't have a family history, she does have multiple cancers of different types at an early age, which alerts us to the fact that there may be an underlying genetic predisposition, and she has a different type of genetic variant called P53, or Leaf-Fraumeni. I'd just like to go over polygenic risk as well, because this is probably the most common type of genetically inherited predisposition. And, all of our genes, we are like a cocktail of a variety of genes from both our parents, and everyone is special. And as I always tell the children in my clinic, they're perfect just the way they are, and I wouldn't ever want to change their genes. But there is a variety of genes inherited from each patient, from each parent, and the additive role of these different types of genes can be complex, so they don't just add up, they can multiply in interesting ways. For example, having auburn-colored hair can increase your risk of melanoma by 2. Having many moles can increase your melanoma by 6. But if you have both auburn-colored hair and many moles, that increases your risk by about 20 times. And then if we throw in carriage of an autosomal recessive disorder of DNA repair, then that risk becomes higher but more difficult and uncertain to calculate. I think Tanya will talk about the polygenic risk scoring later. At the moment, although it's offered direct to patients in some centres, it's really belongs, in my opinion, in more of a research space. Because much of the information that we can see from a polygenic risk score is still the type of information we can see just with our eyes, or that you as a patient will know for yourself. You'll know if you have fair skin that burns easily and have lots and lots of moles. So you will know you will know if you are at risk or not, even without the genetic testing. So then what about my kids? This is a very common question. And I think it's often a reason why parents inquire about genetic testing. In my practice, I refer patients to the Melanoma Institute risk calculators. You can enter in your details only from the age of 18, but that will give you a lifetime risk of melanoma and a 10-year risk. And my advice is that sun protection should be according to lifetime risk. So in this example, we have a 32-year-old male with brown hair, an average mole count. So his lifetime risk is 1 in 10 chance of getting melanoma. That's above the average in the population. And he should definitely be very, very careful with his day-to-day sun protection. But he may not necessarily need regular skin checks with a 10-year risk of 1%. This is the kind of patient who should know their skin and see a medical professional if they have concerns. And so what happens if you do have a positive or a negative test? Tanya will go into a lot more detail about the implications for screening, particularly for other possible associated tumours. But whether your test is positive or negative, melanoma is still the most common and the most preventable cancer in Australia. And no matter what your risk, prevention is the most important, and following those 5 sun-safe rules is key. I'd like to remind you it's never too late to fall in love or prevent melanoma, and you can change your future now just with a hat. Early detection of melanoma is something which is being further evaluated in the National Targeted Screening Program, but certainly for individuals with a known genetic risk, we would have a regular schedule of clinical review. How often and where they are seen will depend on their level of risk, and it will be combined with dermoscopy and possibly other non-invasive diagnostic tests. So thank you for your attention. This looks like a happy mole, but it's actually an unhappy mole, which has been, the pigment's been clumped in a mole from hair removal laser. But I do encourage you to know your risk and then change your future. And at this level, I'd like to hand over to Tanya, who can explain what will happen next if a referral to cancer genetics is made, what discussion you would expect to be having. So thank you, Tanya.
Okay, so hopefully you can see my slides now. So thank you for that introduction there, Linda. I'm going to be talking more about genetic counselling for melanoma risk. So as Linda has already indicated, majority of melanomas are actually due to environmental risk factors with sun exposure, the main risk factor that we see. We also see exposures to other sources of radiation, or some sorts of chemicals can also contribute to risk, in addition to obviously those known physical traits that Linda has already gone through. We really only see a very small number of cases of melanoma that are due to a genetic component. And in Australia, it is no more than 5 to 7% of cases. And even within that kind of clustering of inherited risk, only a very, very small proportion are what we call due to a monogenic risk, which is where a single gene variant is having either a high or a moderate influence on cancer risk. And Linda gave the example of a gene called CDKN2A, which I'll be talking a little bit more about later. Linda also introduced the concept of a polygenic risk score. This is where we have multiple genes, potentially hundreds of different genetic factors, that individually have a very low influence on cancer risk, but they can act together to increase risk overall. And we do have something called a polygenic risk score. However, this is something that is still very much limited to the research space and not really something that we're using clinically at this point in time. We know that there are also some of those rare skin conditions that can also increase the risk of melanoma. But you'll note on this slide, I've actually listed family history in all three of these categories. And that is, of course, because we share genetic factors within family members. We also know that family members share the same physical traits, and family members can also share those same environmental lifestyle factors. When we talk about genetic counselling, we're actually talking about a communication process. It's where a person like myself, a genetic counsellor, collects and assesses personal and family health history information. This helps us to identify if genetic testing is likely to be helpful for that individual and allows the opportunity to discuss the potential benefits, the potential limitations, and even some of the consequences of genetic testing. This can help to make sure that we set the right expectations for what information will be gained and to also help to prepare that individual for the possible genetic test results. All of this information is then used to provide cancer screening, and risk reducing strategies can be put in place. And this is where a genetic counsellor works alongside a genetic specialist, either a clinical geneticist or a specialist who is specifically trained in cancer genetics. In some scenarios, we can also discuss reproductive implications to help guide options moving forward. All of this process is really focusing in on ensuring that a person is making an informed choice as to whether or not genetic testing is right for them. So, when we're doing a genetic test, we're essentially looking for a spelling mistake in a gene. And as Linda's already highlighted, there are two main types of genetic testing. The first is somatic testing, which is looking at acquired genetic changes that have developed at some point in that person's lifetime. And typically, this can be a change that occurs only in the cancer tissue itself. This can obviously sometimes help with establishing the best treatment for that patient. When we look at what we call germline genetic testing, we're looking for inherited cancer risks. This is typically performed as a blood test. These spelling mistakes can occur along a spectrum. Sometimes there are changes in the spelling of a gene that have absolutely no impact on how that gene works. It's just part of human diversity, and we call these benign or likely benign variants. They have no significance to our health. At the other end of the spectrum, though, we see variations in the spelling of a gene where it is clear that that change in spelling stops the gene from working properly. And these are what we call pathogenic or likely pathogenic variants. And if a person has a germline pathogenic variant, it means they've been born with a change in the spelling of the gene that is present in every cell in their body, something that they have likely inherited from their parents. And because this spelling change stops the gene from working, it means it can't protect them from developing certain cancers. And accordingly, we see that person having a higher chance of developing certain types of cancers compared to the general population. It's really important to know, though, that it doesn't mean that that patient is definitely going to develop a cancer, and it can't predict what type or when. It just tells us that their risks across their lifetime are going to be higher than everyone else in the general population. We typically do these blood tests on something called a gene panel. So we're looking for a small number of genes that could explain that particular cancer type. So a common melanoma panel that we test for includes the genes that we have listed there. Sometimes we might test all of those genes. Sometimes the genetic service might select just a smaller number of genes that they think is the most likely explanation for that person's personal or family history. If we do see a gene variant, it could have important implications for family members. And this is because most of these cancer predisposition genes show autosomal dominant inheritance. It means that there is a 50% or 1 in 2 chance that a parent may pass that non-working gene onto their children. And you can see that in this particular diagram. We know that both male and female children can inherit a gene variant, but in some scenarios, the cancer risks might be different between the different genders. When we are assessing from a publicly funded position or a public genetic service, we do have very clear guidelines for who we recommend be referred for genetic counselling or genetic testing for melanoma risk. And this includes a person who has been diagnosed with multiple melanomas under the age of 40, or if they're under the age of 45 but have 2 or more first or second degree relatives that have also been diagnosed with a melanoma or with a pancreatic cancer, or if we see a person with 2 or more tumours that are linked to a condition called BAP1 tumour predisposition syndrome. And these sorts of tumours are shown here. So we know there's something called a BAP1 inactivated melanocytic tumour. We can see uveal melanoma, which is melanoma that can occur at the back of the eye. Cutaneous melanoma, which is obviously melanoma that occurs on the skin. And some other rare forms of tumours called malignant mesothelioma, renal cell carcinoma, which is a type of kidney cancer, and a rhabdoid meningioma, which is a type of brain tumour. If a person has one of these rare forms of tumours, and they also have a first or second degree relative with one of these tumour types as well, that can also be a flag that we need to consider the syndrome, BAP1 tumour predisposition syndrome, which I'm going to be talking about in a few slides. I wanted to just briefly outline the process for a referral. Now, as I've mentioned, in a public setting, we very much use those referral guidelines and criteria for when we would recommend a publicly funded genetic test. If a person does fall outside that public health criteria but are still keen to consider their own self-funded genetic testing, then some public genetic services will facilitate that testing, but not all. There are also some private genetic services that are available. And again, I've given a couple of examples of services that are here in New South Wales, where they will assess for whether or not clinic-funded testing or self-funded testing is available, and obviously provide appropriate risk assessment and genetic counselling. And they are also are some direct-to-consumer options available, where a person could order a saliva-based test kit that can be sent to home. You can collect that sample and then send it off to a laboratory for testing. And the reputable companies do provide genetic counselling at the time of results. Now, obviously, I'm going to be a little bit biased when I also say that there are some good direct-to-consumer services, and I've provided Colour and Myriad as two, I guess, more reputable examples. They're the laboratories that we know of and obviously are aware of their particular standard. But there may be other genetic testing options that are less reputable. So it's something that you might just want to be thinking about if you are thinking about a direct-to-consumer genetic test. In the limited time that we have to talk about the different syndromes that we are aware of that are associated with melanoma risk, I've picked the two, I guess, most important ones from a melanoma perspective. Linda has already introduced the CDKN2A gene to a little extent. We know that this causes a condition called familial atypical multiple mole melanoma. And as we can see in this figure, there's been a few different cancer types linked to this particular syndrome, but the ones that we are mainly concerned about is that risk of melanoma and also an increase in the risk of pancreatic cancer. Now, there is one specific change in the CDKN2A gene that is associated with a very high risk of pancreatic cancer. We don't yet have enough data to know the exact pancreatic cancer risks for some other variations in the spelling of the CDKN2A gene, but we do know that there is likely to be that increased risk above the general population. This is a figure of one of the families that I've been involved in the care of. In this family tree, female relatives are shown as circles and male relatives are shown as squares. And any person who has a black symbol is a person who has been diagnosed with some form of tumour. And we can see that in the generation second from the bottom with the arrows, there are 3 out of the 4 siblings that have all been diagnosed with melanomas in their very early 20s. Some of these have gone on to develop other tumours as well. And of these, 2 were confirmed to have a gene variant in the CDKN2A gene. Obviously, these individuals are having ongoing screening with their dermatologist for the melanoma history. But because of their family history on their father's side of pancreatic cancer, these 2 individuals have also been undergoing pancreas screening through a research study. Now, up until the end of last year, I was actually involved in a pancreatic cancer screening program at St Vincent's Hospital here in Sydney. That study has now closed, but a new version of the screening program is launching around Australia this year, and this study is called APRISE. They use 2 different tests to screen the pancreas to see if there are any early signs that a pancreatic cancer may be developing. And the 2 tests include something called an endoscopic ultrasound and also a pancreatic MRI. They recommend that any person who has a pathogenic variant in the CDKN2A gene, who are over the age of 40, consider screening for pancreas cancer. And this is regardless of whether or not there is any pancreatic cancer in their family. I've listed a couple of sites here that are currently recruiting in New South Wales, and there are going to be some additional sites likely to open soon. I appreciate there's probably a lot of people from other states dialing in tonight as well. And the website that I have shown at the bottom of the screen also has a lot of information about the different sites that are available in all of the states around Australia. So if this is something that you think might be is something you're suitable for, then you can certainly make an inquiry with the team, or we can potentially ask a few more questions during our follow-up time. The second syndrome that I wanted to talk a little bit more about is the BAP1 tumour predisposition syndrome that I mentioned early. And again, as you can see in this figure, there are a number of other cancer risks, not just the melanoma risk. So the main ones are, of course, the uveal and cutaneous melanoma, but also malignant mesothelioma and renal cell carcinoma. And it's important that when we talk about these multi-organ cancer syndromes, it's unusual for a person to develop all of these tumours, but you can see that the chance of them developing these particular types of tumours are going to be a lot higher compared to the general population. But importantly, There are also people out there who develop none of these tumours. And I can say that I have an 88-year-old female patient that has just recently been tested and is known to carry the family's BAP1 gene variant, but she has not developed a single tumour throughout her 88 years. This is, again, the same sort of diagram of a family with a BAP1 gene variant that I'm looking after. I'm looking after this patient down in the bottom with the arrow. You can see that, unfortunately, many of her family members have been diagnosed with related tumours. She herself is currently well, and she's having screening as part of a trial called SMOC+, which I'll talk about on my next slide. More recently, her sister has actually come forward for her own predictive testing. And we're still waiting for her results, but we're either going to be able to help to reassure her that she has not inherited the family susceptibility, or if she has, then we can put in place the same screening recommendations like we're doing for her sister. So for people who have a BAP1 gene variant, obviously because of the melanoma risk, they regularly see a dermatologist for ongoing follow-up. Because of the renal cell carcinoma or kidney cancer risk, we have a Medicare rebate available for an abdominal MRI so that they can have ongoing monitoring of their kidneys, again, looking for any early signs that a tumour might be developing. And we also recommend that they regularly see an ophthalmologist to check for the uveal melanomas. Some of the other rarer tumour types, though, we don't yet have evidence of clinical benefit from screening. And so again, we have a research option where we can coordinate annual screening for these individuals as part of the SMOC+ study that I mentioned. And here we include a brain MRI, to look for the meningiomas. And we also provide or coordinate the abdominal MRI with a volumetric lung MRI. And that's looking for the mesothelioma that could develop either in the abdomen or within the lungs. One of the benefits of being involved in a screening program like this is that we obviously will collect the data and the information as to how many of our BAP1 individuals go on to develop one of these tumours, and importantly, how effectively we can find early signs of these cancers and whether or not that helps us with improved treatment success and improved survival. In my last two slides, I wanted to really just briefly present some of the overall possible benefits and possible limitations of genetic testing. And for many, simply having an explanation for a diagnosis or for their family history provides helpful information. We can obviously take this one step forward by helping it to inform treatment selections or potentially ongoing management, including what cancer screening they should be having. And as I've mentioned, this can include both clinical options and also research-based surveillance options. Through the power of predictive testing, finding a gene variant can then help others in the family understand their own cancer risks. So this can either help to reassure those in the family that have not inherited the same genetic change, or to help people in the family who do have the same gene variant to make those proactive health decisions to implement screening or risk-reducing strategies to hopefully keep themselves safe. And as I mentioned, in some scenarios, it can also be helpful to inform reproductive options. On the flip side, though, it's important that we also recognise some of the limitations or consequences of genetic testing. And we certainly do not have an understanding for every person out there. There's still a lot that we don't know about cancer genetics. So we do still see uninformative results, which is where there might be a clinical suspicion that there could be an inherited risk, but we don't find any gene variants in the genes that we currently know about or can currently test for. There could be other genes out there that we just haven't identified yet. That polygenic risk score might be playing a role, and maybe over the next 5 to 10 years, we'll be in a better position to offer broader genetic testing for multiple genetic factors. I mentioned a spectrum of results. And sometimes it's not clear to the laboratory where along that spectrum that specific variant might fall. So there is a group in the middle that are called unclassified variants, or variants of unknown clinical significance, where we just don't have enough evidence yet to know if that change is or is not impacting how that gene works. I've also mentioned some of the limitations as to our knowledge on exact cancer risks associated with particular gene variants, or there could be other cancer associations that we just have not recognised yet with these genetic changes. Linda raised a couple of interesting points that sometimes people choose not to know if there is an inherited risk. And we certainly support that choice if that's how they view this information. We certainly never force anyone into undergoing a genetic test if they're not comfortable to do so. We also see that some people can have very strong emotional responses to learning about an increase in cancer risk, and this could be heightened health anxiety or cancer fear. And again, this is why it's really important to have someone like me as a genetic counsellor to help that person as they're adjusting to learning this information. And finally, one of the major, consequences of genetic testing that we have at the moment is that it can sometimes impact the ability to obtain certain types of insurances. Now, this is largely referring to life and income protection insurance. Importantly, there is a current ban on the use of genetic information for new policies up to certain thresholds. So up to $500,000 or $4,000 a month for income protection, an insurance company is not able to use any genetic information to deny cover or to change the cost of a premium. But if you are actually applying for a life or income protection policy over those thresholds, then that's exactly what an insurance company can do. The government have committed to bringing in new laws that will actually stop the use of genetic information in insurance entirely, but we still don't know what the timeline of that will be. And so as of today, this is something we still address with every patient who's considering genetic testing. The two very important pieces of information is that health insurance is in no way impacted, and no one is ever required to provide information about genetic testing that their family members have had. It is only if they themselves have undergone genetic testing. Now, that's all of my slides. I know I've probably gone a little bit over time, but hopefully we can address anything further in the questions later on. Thank you so much for your attention.
Oh, bear with me one moment. Oh, okay, great. Thank you. Thanks so much, Tanya. That was a great presentation. I'd just like to introduce Grace Passfield now, who's our patient speaker for this evening. Grace is a physiotherapist and a mum of two from the Central Coast in New South Wales. Diagnosed with advanced melanoma in 2021, she underwent immunotherapy and is now cancer-free. Grace is passionate about sun safety and regular skin checks, and proudly contributes to national efforts to improve skin cancer screening. So welcome, Grace, and I look forward to your presentation.
Thanks, Shannon. I'm just going to share my screen as well. All right. So thank you for inviting me to talk about my melanoma experience. I'm speaking from Dark and Young country in New South Wales. It's been a long 4 years since our world was turned upside down. I was 33 years old when I was first diagnosed with metastatic melanoma, and at the time I had 2 small boys. This photo on the left was taken around the time that my symptoms first started. So in terms of myself, a bit of background, I was diagnosed with ulcerative colitis back in 2007, which flared up significantly in 2012. And that resulted in me needing to be on some immunosuppressing drugs briefly before I had my whole large bowel removed. They told me I was at increased risk of SCCs and skin cancers, so I avoided the sun pretty meticulously from there. But I did have my first SCC removed in 2014. I'm fair-skinned. I don't spend a huge amount of time in the sun, but I have had some pretty nasty sunburns in my time, and a very strong history of SCCs and BCCs, but no personal family history of melanoma. So my melanoma, like a small percentage of melanoma patients, was of unknown primary. My symptoms first started around November in 2020. My youngest was about 8 months old. I started coming out with these random bruises without a history of trauma. You can see there's two of those bruises on my chest there. The very blue one actually started as a little lump, and I also was getting these just small little subcutaneous lumps popping up all over my body. That dark blue one in the photo was a little blue lump, and I pushed it a bit too hard and I felt it go pop, and then there was this huge bruise that came out. I had them on my arm and my neck, and it looked pretty terrible. I had some in my hand and on my face, but otherwise nothing was out of the ordinary at all. I had no pain, no other symptoms. I mean, I was tired, but I had a pretty small baby, so of course I was tired. But otherwise, yeah, everything seemed normal to me. I also had an enlarged lymph node in my sort of upper thigh groin region that I noticed when I was doing exercise. Over the next couple of weeks, I saw my GP a few times and had some blood tests that initially looked quite reassuring. But then given the lymph node in my leg didn't go down, and I kept getting more and more and more of these lumps to the point where I lost count of how many I had, I was eventually sent for an ultrasound of the lymph node. Oh yeah, and I also had a chest X-ray as well. So from after the blood test and the chest X-ray and the ultrasound, I was sent for a biopsy of that enlarged lymph node on a Friday afternoon. The radiologist at the time would have known that is looking like it was melanoma, because the sample he withdrew from the biopsy would have been a melanin stain sample. It would have been a black sample. So I had an immediate CT, chest, abdo, and pelvis. I was called into the GP office the next morning, and she told me that this is what we were likely looking at, that it was likely metastatic melanoma. And I was obviously devastated and in shock. I was just there with my baby by myself. I don't know how I managed to drive home. But we crawled through the next few days waiting for a tissue confirmation, just hoping that that's not what it was going to be, and it was all just a big mistake. But come that following Tuesday, we got the confirmation of metastatic melanoma. I was lucky in that I got an urgent appointment with an oncologist the very next day, who was really lovely and really reassuring that hope wasn't gone. I was quite convinced that was the end of the road for me. I was going to die, and very quickly. But he said that given the breakthroughs with all the immunotherapy with melanoma treatment, there was certainly a decent chance that I would be able to respond to treatment. I didn't have any formal genetic testing. They just did the individual testing on the melanoma sample itself, which showed it was a wild type, so I couldn't have any of the targeted therapy for the melanoma, but I was recommended to start on the combination ipilimumab and nivolumab as soon as possible. The oncologist sent me off for a PET scan and an MRI brain, just to get a full picture of where things were up to. But he didn't think I was going to have any other metastases in my brain or my bones because I didn't have any pain, I didn't have any symptoms. But then he called me that next day, the day that I had the scan, to tell me he was very sorry, but I did have very widespread metastatic disease, subcutaneously and also in my lungs, multiple lymph nodes, my liver, my spleen, my bowel, throughout various bony sites, and also a few small lesions in my brain, in my cerebellum. And it you can see from the scan, I mean, apart from my brain and my bladder, the majority of the big black spots are all melanoma. It took me a really long time to be able to look at this scan because it was just too horrific for me to look at. But the end result is quite significantly different. So the very next day, I was booked in and started treatment. So treatment for me, like I said, I had the combination of ipilimumab and nivolumab infusions. I had 4 rounds of the ipi-nivo, 3 weeks apart. You can see there on the left, I was breastfeeding my baby at the time, and he had a very short, sharp wean. It was only about 3 days between finding out that that's what I was going to have to do and actually starting treatment. He coped very well. You probably don't want to look in too closely, given what I'm doing, but there are 2 big bruises on my chest and on my arm, which were mets that were bleeding. Anyway,
sorry to interrupt you, Grace.
Yeah.
Sorry, we just can't see your slides. If you could put them on presenter view.
It is on presenter view. Oh.
We can see like 4 or 5 slides. Yeah.
Can you see them now?
They're still small, but at least now we're on the one that you're talking about.
Oh, that's so strange. Okay. Okay. Sorry that you can't see them properly.
No worries. And we can't see your camera
on,
either, just so you know.
Yeah, I can't turn my camera on. I tried, but I don't know.
No worries.
Anyway, so after I had the 4 rounds of the 4 rounds of the induction therapy, the combined IPI and Nivo, only just managed to get through the 4 rounds of IPI Nivo. We got to the 3rd round, and I was very, very unwell, and I'll come back to it, but we said, oh, look, is the 4th round going to kill me? And the oncologist said no. I said, okay, well, let's do the 4th round and clean up the mess later, which is what we did. And then after I finished those 4 rounds, I switched to Nivo every fortnight, which I did for 3 years, and then a year of every month. In terms of side effects, we joked when I first saw the oncologist that I was unlikely to get colitis, being one of the more common side effects of the immunotherapy, because I didn't have a large bowel. But the irony was I ended up with severe gastroenteritis. So all of the bowel and gut tract that I had left all became incredibly inflamed, and I was very, very unwell. I had a couple of hospital admissions for IV fluids and IV steroids, and then eventually ended up seeing a gastroenterologist and having scopes, and then I was started on a different immunosuppressing drug, infliximab. I also had a short bout of pancreatitis, which was thankfully managed with steroids. My thyroid failed pretty early on in the piece, so I've ended up on Thyroxine forever. I had chronic sinusitis. I still have a bit of chronic sinusitis. It's slowly improving, but was quite annoying throughout. And I also had some really strange lumps in my eyes, which turned out to be inflamed tear ducts. So I don't know if you can see the photo, but I ended up having to have a biopsy of one of these lumps in my eyes to see if they were new mets, and it turned out they were just inflamed tear glands. So I just have ongoing issues with dry eyes. That's a whole other thing. But overall, apart from the gastroenteritis, which eventually we got control of, I feel like I was quite lucky in that none of the side effects that I had were treatment limiting, and I could continue have the treatment that I needed. With the gastroenteritis, as I said, I had really severe dehydration, partly because of the lack of bowel that I have. I was on high dose oral steroids and IV steroids. After failing to come off that, I ended up going on to infliximab under a gastroenterologist. Unfortunately, after a few doses of infliximab, I ended up having a really severe reaction, and my whole body blew up and broke out in hives, needing more steroids and more things to get back on top of all of that. I eventually ended up switching to another drug called vedolizumab, which was gut selective, which was even better, really, because it wasn't immunosuppressive, so it wasn't going to potentially impact the immunotherapy for the melanoma. And I've managed to come off that as well without a recurrence of the gastroenteritis. Just to throw a spanner into the works as well, 10-12 months into immunotherapy, I had a nasty fall and an injury where I destroyed my ankle, and then over the last couple of years I had a couple of surgeries to repair and replace eventually my ankle, which didn't have anything to do with the melanoma or the treatment, but it certainly made life more difficult for me. The other significant implication I did have from the melanoma treatment was, after I broke my ankle, I ended up with a new lung lesion that snuck through while I was on treatment. I had a couple of weeks of radiation therapy for that lung lesion, which ended up giving me, we think, some localized osteoporosis, and then I had a couple of rib fractures from coughing after having some pneumonia, and ended up having to get those ribs plated by a cardiothoracic surgeon. So I'm part titanium these days, but I was really lucky that was able to be managed as well, I think, and I've got no pain and no issues from that anymore. So 4 years later, last year I was having monthly immunotherapy. Then we decided, look, let's have a good look at these lesions now, see what's left. There wasn't a lot left showing up on my PET scan. There was still a couple of spots on my liver, so we biopsied one of those. And the original lymph node that was biopsied was still hot on the PET scan, so we biopsied that as well. And they were thankfully all clear, just showing inflammatory cells and no more melanoma activity. So we've decided that everything is looking all clear now. I finished treatment in December last year. So it's been 6 months since then, and everything is looking good. I'm still having 3 monthly PET scans and MRI brains, and all looking good from that perspective. This is my latest PET, which was done last week. I haven't formally had the results from it, but I had a little cheeky look online, and it's also still looking fine. I see the oncologist tomorrow, and I'm sure he will be saying that everything's looking great. So yeah, overall, my melanoma experience has been really, really difficult, but I'm really lucky that I had really, really wonderful family and friend support, and a really wonderful partner who's been incredible throughout the whole process. I've had really great support from the Hunter Melanoma Foundation through all of these last few years, and I've been a pretty regular participant in the MPA groups when I've been able to with the kids. I guess that's it. I follow the same messages as everybody else about the importance of looking after our skin. I'm really particular with the kids being in the sun and checking the UV and using good sun protection and staying, avoiding the sun at those peak hours, and trying to spread that message around and encourage people to have their regular skin checks. But yes, that's my story. Thank you so much. Hand you back over to Shannon.
Thank you so much, Grace, for courageously and generously sharing your complex and difficult sort of journey with melanoma and your treatment with everyone this evening. I'll just bring up my screen one moment. So just acknowledging we're just on 8 o'clock now, but for those that are able to remain, we can still go over for another few minutes, just in terms of questions. Just give me 1 second. Right, just give me 1 second. I'll just find just jumping into the questions here. Okay, so I just noticed some comments there from Paul just in relation to insurance, and I think that issue was covered off by Tanya, so I might just move past that one if that's okay. So I've just got a question here, and this may be for Tanya or possibly for Linda, just whether a parent, being a father who tested BRAF plus stage 4, who is being treated Zelbref, can they pass on a genetic change to an unborn child?
The BRAF, no. The BRAF mutation is a mutation which will occur only in your melanoma, and it's not something which can be inherited.
Great, thank you so much, Linda. So this question has just come up. I've had several family members who've had cancer, but getting information on the type of cancer they had once passed has been challenging. Do you have any tips on how to address this? That may be one for you, Tanya.
Yeah, it's something that we obviously have to deal with quite a lot in our clinical services when we're doing a risk assessment. Obviously, we can assist to a certain extent, but we do rely on family to have as much information as to potentially where family members were treated for their cancers. We do use death certificates to verify a lot of records. When we have access to, we can also apply for release of information from the cancer registry records. We usually require written permission from the next of kin from that relative. One of the biggest barriers to that, though, is we can only access cancer registry records once a person has been deceased for more than 30 years. So we have this window of time where we can either have that release of information form signed from a next of kin and approach the hospital directly where that individual was treated to see if the hospital records are still available. Most hospitals will keep medical records for at least 7 to 10 years up and after a person has passed away, but then after that, obviously those records are going to be destroyed. And then there's that next window, which is the cancer registry, but we can't access that for more than 30 years. So we do try, and it's something that we do try to do when we are working up that family history assessment.
Great. Thank you so much. That's really detailed and helpful for everyone. So this question here, just around what proportion of uveal melanoma is genetic versus environmental?
Well, it's less than 5% would have a known genetic predisposition that's inherited. I mean, that said, not all cancer is environmental either. Unfortunately, terrible things happen to wonderful people. And I just wanted to say, even though sun safety is really important, I also don't want anyone to feel like, whatever terrible things have happened are their fault.
Yeah. Thank you, Linda. And this question here, is there a short version as to why pancreatic cancer increases the risk of melanoma?
I don't know if I would actually say that pancreatic cancer increases the risk of melanoma. I think what we've been trying to communicate is that there is a syndrome where we do see, I guess, a shared development pattern for those two cancers. And I suppose it comes down to the role of that gene in our bodies. So all of the genes that we talk about that can influence cancer risk, these genes actually have a role. They create a protein that has a specific job that it has to do in all of the cells of our body, but certain proteins are going to be more important for certain parts of the body. And I guess the simple way of thinking about it is obviously the CDKN2A gene is present and active in our cells of the skin. It's also active in the role of our pancreas, and obviously these changes do have just that associated sort of link in those parts of the body. I guess I wouldn't really say that there's a causal link though between pancreas cancer causing melanoma or vice versa. It's just that it comes down to the biology of what that particular protein is supposed to be doing, or the cells of the body in which that protein is sort of more active. Anything you wanted to add to that, Linda?
Yes, I agree completely. It's not so much that one causes the other, it's just they have a shared risk, shared underlying cause.
Great. Thank you so much. And just the final question just here this evening, just is the test for CDKN2A most reliable as a blood test or a saliva test?
So generally we do our genetic testing as a blood test. I guess the main rationale for that is, we are looking for a change that's present in all of the cells of the body, and blood tests are pretty easy, to do, generally speaking. The saliva test kits are usually pretty accurate as well if they're going to reputable labs. The biggest issue I would say with a saliva-based test kit is you have to be very careful with how you collect that sample. And if you're a patient doing an at-home saliva-based test, you really have to make sure you're not eating or drinking anything before the collection of that sample, because it relies on actually getting some cells off the inside of your cheek that have your DNA. It has to have enough of the sort of genetic information or your DNA from the cells of that lining of your mouth that gets into the saliva sample for them to have enough DNA to do the testing. So it's more around the quality of the sample collection than the overall sort of testing process. But we just find it is typically more reliable to just do a blood sample, because you're more likely always going to get enough DNA from a blood test, whereas sometimes you can have smaller amounts of DNA from a saliva sample.
Great. Thank you so much. I think that is all of the questions that we've got from the presentation this evening. I'd really just like to acknowledge and thank you so much, Linda and Tanya and Grace, for your time this evening and just generously sharing your knowledge and sort of expertise for this forum. And thank you to everyone who's attended this evening. Just a reminder, the recordings of these webinars will be on the MIA and the MPA sort of websites over the coming days. And we do have those couple of other sessions coming up in the next couple of Tuesday evenings. So I'd really welcome and love to see attendees at those events as well. So thank you so much. And hope you all have a good evening.
Thank you.
Thanks.